let's move on to what is really becoming a new observation we're all having is young people getting colon cancer. We didn't sign up for this, so I know we're all seeing them. And you know, I've got a 17-year-old now, there's 20, 30, 40-year-olds,
16-year-old.
16-year-old. So anybody got any idea what's going on?
I think all of us would want to know what's going on. I mean, I think we're all seeing those patients, just as you're mentioning. The biology appears to be much more aggressive in quite a few of these patients, much more so than our older patients, and they're not responding to the therapies that we've been giving as a standard to all of our other patients.
Seems like a different cancer. Yeah,
completely.
So the first topic that always comes out when this emerges is, should we change our screening? And you know, should we move this back from 45 or 50? What do you think?
I'm thinking the numbers are starting to get there, that maybe we should start screening at 40, or having more awareness that when a younger patient presents with GI symptoms, don't just send them away and say,
it's not a hemorrhoid, it's not a tear, scope them.
Take a peek early.
Yeah, take it seriously. Any thoughts on what's going on? Are these like couch potato-y, you know, unhealthy people?
Yeah, well, apparently not. I mean, as data that's going to be presented here at ASCO would suggest they're very similar to the older patients. They're certainly not have greater obesity. The body mass index, for example, is the same between the different age groups. I certainly think that you would want to look for something environmental or something habit-based. It seems like that would be the obvious thing, but until we can collect enough data from a large enough number of people, I just don't see how we're going to tease it out.
Yeah, my observation is these are really healthy people. I joke that they're marathon running and cardboard eating and all of that. And so I've been focused on, and some work we're doing is around the microbiome, is the bacterial composition and what, you know, other than Starbucks and cell phones, you know, what else has changed? And you know, maybe it's antibiotics, maybe it's we wash our hands too much and don't eat enough dirt and all of those things with kids today. But we need to figure it out, as Cathy pointed out.
Definitely. I mean, that's one of our research interests at MD Anderson. We're doing a longitudinal sequential analysis on these patients.
Yeah. And maybe, just maybe, we figure out some science that, you know, brings new stuff to the table that might affect screening, for example, that might tell us which yogurt to eat or whatever it will be to prevent the disease. So it's really important research.
I think it's important to mention, I think we all know this, that they're presenting more often with left-sided tumors, rectal tumors, but yet we're told the left-sided tumors have better survival. But this seems a little bit different in this very unique young patient population.
Peritoneally as well. I mean,
a lot of peritoneal disease.
And maybe it's they're young and we're affected by it more, but it does seem like it's worse. And genetics, you know, there's some evidence out there that there's a slight difference in genetic profile, but they're not fundamentally different tumors, right? They're not biologically all that different, but kind of clinically behaving. So the main message for us is, how is this affecting your recommendations to, you know, and you see one of these 35-year-olds come in, does it change what you do now?
You know, unfortunately, it doesn't, because we don't have good data. I mean, clearly, as we've suggested, the biology is so much different. It has to be. They are mostly left-sided, which we think is better, but they are more aggressive. They don't seem to respond as well. But we just don't have good information on the biology to know what to do differently. And so I think we're kind of forced into doing what we do with everyone else until we know better.
Yeah, we tend to give, we say they're young, they can take it. So is this where you give 6 months for sure of adjuvant therapy?
Oh, for adjuvant, once again, though, I look at everything else in regards to the matter. I'm sorry, in regards to data for these patients. But in regards to metastatic disease, I will be more aggressive than normal on these young patients because their performance status is usually fairly good. I love to use FOLFOXIRI in this setting on these patients.
Yeah, but but this is also a patient who's raising a family and trying to go to work. And so when we put our foot on the pedal a little harder, it is more disruptive too, right?
But I've had patients that still function, work, do everything else. I think it's really important that we're talking about the young patient population, that we're talking about fertility preservation, though, as well, because that's not discussed enough with patients.
We don't discuss that very much with our patients because usually they're past that those ages. But yeah, it's becoming an increasing issue with banking, whether it's eggs or sperm and the like. Any other young patient observations?
The other thing that I make sure I do, and I try to do this in all the patients, but especially the young ones, is get the next-gen sequencing on these patients. Know as much as you can about their disease walking into it, just because if there is something there, you might be able to help treat it. You might find something that's more genetically linked, so that way you're able to both take care of them and their families better.